Hello, my name is Nikki Campbell and I'd like to welcome you to this lecture. The topic for this lecture is cochlear implants, the assessment of adults and children. And in this lecture we're going to be covering a few topics. In the first instance, I want us to pause for a moment and consider why we in fact do an assessment. We'll then be looking at the value of a multi versus an interdisciplinary team. We'll also be looking at the role of different members within the team, for example, the ENT consultant, the audiologist, the speech-language therapist, the teacher of the deaf, the hearing therapist, and the psychologist. I'll also be providing you with an example of an appointment structure. We'll be looking at the variables that might influence the outcome with a cochlear implant, and I'll be using 3 cases to illustrate this. Okay, so why do we do an assessment? Over to you. Well, perhaps you're thinking that it's really important to make sure that the person meets the criteria. So we'll assess the person to make sure they do in fact fall within the criteria range. You may be thinking it's really important to consider specific risks. For example, anesthetics. We want to make sure that someone doesn't have an underlying heart condition which can affect their well-being when they go for cochlear implant surgery. It's also important to see the assessment process as a two-way process. We're getting information about the patient, but similarly we're giving information about what is a cochlear implant, how does it work, what are the limitations, and what they can expect with a cochlear implant. We need to consider the unique variables that will influence the outcome. For example, we know that for children, the younger we implant, generally the better the outcome, because we're able to make use of the neuroplasticity that goes together with being young. It's also important to find out whether there is a cochlea. In some individuals, the cochlea may be absent, or it may be abnormal. Is it possible to insert an electrode array? Are the person's expectations realistic? We need to make sure that they know what they can expect with the implant. What sort of communication does the person use in their day-to-day functioning? Do they use spoken English or spoken language, or are they perhaps using sign language? And how do we work around that to fit into their lifestyle? So what is the difference between a multi and an interdisciplinary team approach? Well, with a multidisciplinary approach, we have professionals that work on their own. For example, we may have an ENT consultant at the hospital, we may have an audiologist that is somewhere away in an audiology clinic, a speech-language therapist that's in a different building, and all of these individuals assess a child or an adult individually, and then liaise with each other afterwards in terms of care. How an interdisciplinary service differs is that we tend to have all of those people under one roof, and they work together on a daily basis, popping into each other's appointments and working together in terms of writing one report and coming up with comprehensive and integrated recommendations. So we've already discussed who the different team members might be, and this of course will differ depending on the country in which you find yourself. In some countries we have hearing therapists, for example in the UK, but I know that there aren't hearing therapists in some other countries, and I'll be telling you a bit more about what the hearing therapist does shortly. Okay, so let's start with looking at the role of the ENT consultant. And what I've done for the purpose of these slides is that you'll see there's an arrow at the bottom where we have pre-implant in red, so that is the frame around the box on the left-hand side. Then we have in the center the surgery, and then finally the green box on the right-hand side, which has to do with post-implant and the role that the ENT has there. For the purpose of today's lecture, we're focusing on the red box on each screen, but I thought it would be useful to include the other components for you to go back to in the future if you would want to. So the ENT consultant takes a very good case history in terms of the hearing loss history. It's important to know when the hearing loss started, what the possible cause might be, and also the surgeon needs to look in terms of the medical history. Is the person fit for surgery? Is there something special that needs to be considered or done? Need to consider things like the anesthetic risk, ossification risk, where in the previous lecture that I did, I told you about meningitis and the fact that there's ossification or hardening within the cochlea. So we need to take that into consideration. The ENT consultant will look at the ear health, will examine the ear externally, but also the ENT consultant will refer on further for radiology, for a CT scan and MRI to be able to see what the ear structures are like on the inside, and we'll say a bit more about that in a moment. It's also important for the surgeon to provide information about the surgery, what can the patient expect, and also to provide information about the importance of meningitis vaccination. With any form of surgery, there's always a risk of infection. So having a meningitis vaccination ensures that this is not a complication following surgery. Okay, so let's look more closely at the CT and MRI scan. This varies across countries. At the service at which I work here at the University of Southampton, we like to request both because they give slightly different information. So the CT scan, also known as computerized tomography, gives us information about the anatomical orientation of the cochlea. It also tells us about disease and abnormalities within the bony labyrinth. MRI, on the other side, or magnetic resonance imaging, looks for fibrosis or ossification. It also looks for cochlear abnormalities and also auditory nerve abnormalities. In some instances, we may find that the auditory nerve is completely missing, or it could be particularly thin. So moving on then to the role of the audiologist, which is really at the core of the matter for you and I as audiologists working in this field. For us, it's important to get a history about the hearing and the use of hearing aids. And on the next slide, we'll be looking in a bit more detail at the aspects that we need to cover. We're also involved with the audiological assessment. And here at Southampton, the tests that we're using include otoscopy, tympanometry with reflexes, ABR, cochlear microphonics, and autoacoustic emissions, and I'll be saying a bit more about that on one of the later slides. We also look in terms of aided and unaided audiometry, and particularly speech perception, using tests such as CUNY, BKB, and in some cases AB words. For us, it's also very important to consider aspects like tinnitus and balance in these individuals. We want to make sure that we don't aggravate problems that are already there. So from an audiological case history perspective, the information that we're looking for is the onset of the hearing loss. When did the hearing loss start? What was the possible cause? How old was the person when it was diagnosed? When were hearing aids fitted? And the use of hearing aids. As we know, for someone that has become deaf over time, we have a better outcome if the person has worn hearing aids, which has helped to stimulate the auditory system and the nerve. We also need to find out if there have been any recent changes in the hearing. Which ear is better? Does the person have problems with tinnitus? How long have they had the problems with tinnitus? Which ear? How distressing is it? Does it help when they wear a hearing aid? Do they receive any medication for it? And also with balance. How has the balance been affected for this individual? Particularly if they've had an accident or trauma or something, how are they coping on a day-to-day basis? And we may need to do a full workup in terms of balance. We need to inquire about telephone use. In most instances, by the time someone comes for a cochlear implant assessment, they're no longer using a telephone in a conventional way. So they're using text messages, for example, on a mobile. We need to inquire about ear infections, any ear operations. And with children, we want to get a general feeling in terms of how are they doing day to day at home, at work, and in their social life. With children, we want to know about their speech and language development, how they're responding to sound, their awareness of environmental sounds, are they responding to any speech. If we look in terms of the audiological assessment, we need to do pure tone audiometry. This gives us information about the degree of the hearing loss and whether the person meets the criteria. It's also helpful to consider doing electrophysiological tests if we're concerned that there may be a functional component, for example, if someone is feigning a hearing loss or if they're unable to respond accurately during our audiology testing. It also gives us information about a person's suitability for electroacoustic stimulation, something we've discussed in the previous lecture. We need to do a hearing aid evaluation to make sure that the hearing aids are working according to specification, so that we know that the person is getting the best result with the hearing aids. The objective tests that we can do include auditory brainstem response testing, And this is helpful in terms of determining the degree of the hearing loss. It's helpful, as I say, in terms of excluding the possibility of functional hearing loss. And when combined with autoacoustic emissions and cochlear microphonics, we're able to identify those individuals that have auditory neuropathy spectrum disorder. We also do tympanometry and reflexes. We need to know about the middle ear status, whether it's healthy. And the reflexes are really important because they give us additional information about the person's hearing. So for someone with a severe and profound hearing loss, we wouldn't expect to have reflexes. If we do obtain reflexes, then we need to look further in terms of why that is the case. In terms of the speech perception measures that we use here at the University of Southampton, we use the BKB sentence test, which we do with the person repeating the sentences that they hear, where there is no visual information. So in other words, the person can't lip read. It's really their perception of sentences that are presented through the auditory mode. We also do the CUNY test, and the CUNY test we can do under two conditions. One where there is only lip reading. In other words, the person has a screen with the person's face and they need to repeat what they think the person is saying based on lip reading. Or we can do this test where we present sound to get an idea of how the person does when lip reading is combined with auditory input. We can also do the AB word test, which is a speech perception test which uses words like void or sheep. That's a much more difficult test. And the reason it's more difficult is because you don't have the linguistic context. If I'm doing a sentence test and I hear umbrella and rain, then I can guess that the sentence might be, remember your umbrella, it might rain today. But if you're only hearing the word void, you've got a very short window to hear what is said, and there isn't much context to derive the meaning. As I've mentioned in the previous lecture, speech perception materials tend to differ greatly across the world, and this is perhaps something that we need to look at in terms of looking at more standardization. Moving on then to the role of the speech-language therapist. The speech-language therapist looks in terms of communication. How does this person communicate in terms of written language, in terms of spoken language? Are they using signing? What is their natural way of communicating? They also look at the speech. We know that in some instances people with deafness will distort their speech to get a bit of tactile feedback, so their voices may become higher, or they may be doing something in order to feel the sounds that they are producing. We need to look at the voice. We need to look at the ability of the person in terms of how they communicate if they don't have spoken language. What is their body movement? Are they giving an indication of being involved in the world and of hearing? And the speech-language therapist is also very, very important in terms of planning forwards in terms of the care and the management for individuals. The role of the teacher of the deaf. The teacher of the deaf is a teacher that has further expertise with deafness. So it's a teaching qualification that they have in the first instance, and they then train further. These are members of the team that are invaluable in terms of looking at hearing aid use, but also assistive listening devices, the FM systems and other devices that can be used together with both hearing aids and cochlear implants to improve the outcomes. In some instances, we find that children or adults may be reluctant to wear hearing aids, and the teacher of the deaf is one of the people that can help, particularly with children, to help facilitate children adapting and getting used to hearing aids during that trial. They gather and guide information about educational placement. What is the best place for this child in terms of schooling? They give advice in terms of communication mode. And they're also very good in terms of looking long-term for the child, managing and providing those services that are necessary to support the child. The hearing therapist is very similar to the teacher of the deaf, the difference really being that they tend to work with adults. So the hearing therapist will look in terms of hearing aid use in adults, and if necessary will help in terms of establishing hearing aid use. And their role is a bit different from the teacher of the deaf in the sense that they will go into the work environment and see how the person is coping there and get some idea of how the person does socially in their day-to-day living. They will also liaise with different groups in order to set up support and structure for the person both before the implant and obviously afterwards as well. They're an invaluable member of the team in terms of tinnitus and helping with tinnitus training to reduce the very negative effects that tinnitus can have. The psychologist. Psychologist is there for a number of reasons. The psychologist assesses the person's emotional well-being. The psychologist will also look at the developmental stage of a child and cognition. Also important is to look at the expectations of the cochlear implant. Are these realistic? And then there are a lot of dynamics around hearing impairment, and it's very important that families are well supported in terms of coming to terms with hearing impairment that their child may have, or in the case of an adult, in terms of the impact that that has on them, their lives and their family. So here we come now to an example of an appointment structure. In most services, the typical place to start is with the hearing and speech tests, and you'll see that in the top right-hand corner of the screen. After that, the person is typically seen by the medical consultant, who will look in terms of the fitness for surgery. They may then refer on, as you can see, in terms of a CT or an MRI scan at the bottom of the screen or towards the middle of the screen. At this point, we may also look in terms of making sure that the person is in fact using a hearing aid or has had a hearing aid trial. We may also look in terms of setting up home and school visits that the teachers of the deaf, speech language therapists and hearing therapists may do. Once that's completed, we look in terms of the other assessments, for example, the communication assessment, the psychology assessment, and during this time we're also giving information about cochlear implants, what a cochlear implant is, the different companies, how an implant works. If necessary, we can organize objective hearing tests. So in other words, the person will come back for more audiology assessment. And something that people find incredibly useful is user group meetings. So this is something that we use routinely at our service, where we invite people with cochlear implants to come in and talk to people who are considering an implant. This is incredibly helpful for people to be able to share firsthand what the experiences are of a cochlear implant. What was the surgery like? How does the cochlear implant sound? How did it sound in the beginning? Was it as robotic as everyone said? How long does it take to start feeling a bit more normal? And then, of course, there is also a session to talk more about device information. On our website at the university, we have a very helpful tool where people can then also go online and compare the company's different products. Once we've done all of that, and we've looked in terms of the expectations, the purple box at the bottom, we can then start to look in terms of making a decision if the person is in criteria and everything else is in place. And from there, we can then look in terms of scheduling an appointment, which leads to the first medical appointment before the surgery, and so we then continue with the process. So I have a question for you. We've spoken about the team that is involved with the cochlear implant process. Should the director of a cochlear implant team represent a particular professional discipline? Or could it be, as I've indicated there, someone from a purely management or financial background? This is a very interesting possibility to consider. And in essence, if we have someone that has expertise within one of these areas, they obviously know a lot about cochlear implants and have a sound understanding for that. But they may not necessarily have the management and financial background. If our director were to be a management or financial person, they would obviously understand the money side of it very well, but they may not necessarily have an understanding of the cochlear implant process. Essentially, it could be either individual, but both of those individuals would need to have a sound understanding and grasp of the other person's realm or reality. So what are the variables that can affect individual outcomes? Well, in the first instance, it relates to the design. The electrode design, is it a standard electrode array? Are we using a split electrode array? What is the speech processing strategy that we're using? How reliable is the device? We want to make sure that the company that we're using has really reliable products. There are individual patient characteristics, such as abnormalities within the cochlea, or there could be associated disabilities. We may have a child that has cerebral palsy and hearing impairment. And then the cause of the deafness. Is it something like meningitis? Has there been trauma? or what is the underlying cause for that. That will help to direct us in terms of our assessment and also get an idea of what the potential outcome could be. Then on a cellular level, what we find is that there are factors that affect the spiral ganglia cell survival. And we need to look here in terms of things like auditory deprivation, where someone hasn't had hearing aids for a long period of time, where a hearing nerve has not had very much stimulation. We need to consider the duration of the deafness and, of course, the age of implantation. In terms of social and educational factors, we need to look in terms of the communication mode, we need to look at the expectations of the person and the family. Socioeconomic status is also shown to play a role. And then there are also novel variables which are quite exciting. So what is the impact of auditory training? Do specific auditory training programs result in a better outcome for the person? So what I'd like to do here, and I'm referring you on to 3 different videos that you'll be able to have a look at, is specifically what are the variables that affected these particular individuals. Now with Jonathan, we find that this is a child who received a cochlear implant at the age of 8 months. He'd had meningitis when he was 3 months old and had a profound hearing loss as a result. And in this video you can see during his initial tuning appointment how he is responding to sound for the first time. So what are the variables here that are going to influence this child's outcome? Well, in the first instance, he's very young, so he's got very good neuroplasticity. As you can see from the video, his parents are supporting him incredibly well. He's also got an awareness of sound straight away with that initial tuning appointment, so the outcome looks very favorable based on the initial tuning appointment. In video 4, you can see Kelly's cochlear implant activation. Now, Kelly is someone who as an adult has had problems with cystic fibrosis, and she's needed to take ototoxic medicine that has affected her hearing. As you'll see from the video as well, she's also had a lung transplant. So this is a young woman who appears very healthy in this video, but she's had really significant health problems. What's amazing in this session is that we can see how well she's responding to sound in the very first session. And she's in fact requesting that the levels are taken up. Amazingly, she's able to do some speech discrimination in the session. In other words, to be able to hear the difference between words, which is quite remarkable for the first session. Now for Kelly, there are a number of positive factors. One is that she lost her hearing very recently, within the last year. So her impressions and her memory of sound and of language are already well imprinted. She's already acquired speech and language. She's highly motivated, as you can see here. She's clearly a very bright woman as well. And she's very committed in terms of getting back as much hearing as she possibly can. So again, this looks very promising in terms of outcomes. I'd like to contrast this with Melissa, for example, who does extremely well in her own life. However, she's chosen to become a non-user. In other words, she received a cochlear implant when she was 8 years old and hadn't been well amplified and fitted in terms of hearing aids prior to that. She grew up very much using sign language and felt very comfortable within the deaf community. So when she received her cochlear implant at the age of 8, which is after the ideal period in terms of neuroplasticity for children, which is really the first 2 or 3 years of life, and she only received her cochlear implant at the age of 8 years. So for her, she didn't like the sound quality. She was already established using her sign language, so she found it to be a hindrance rather than helpful in her life. Being a child, she conformed and she wore the cochlear implant, the speech processor, for 4 years. But then got to a stage where she said to her parents, I really don't want this. So as you can see, she's very competent in her communication. She's an excellent communicator, does very well in her own community, signs very, very well, and is very articulate in her use of sign language. But for her, a cochlear implant has not been the best decision. So in conclusion then, we've seen that teamwork allows for an integrated service. So we're able to offer the best possible service we can to patients. We've also seen the importance of recognizing that the team compromises and consists of different players that need to take part and make the decisions in terms of whether cochlear implants would be a good prospect for a particular person. We've looked at the variables that we need to consider in terms of predicting outcome, and we've seen how important it is with a team also to not only be getting information and assessing a patient, but also providing information about what a cochlear implant is, how it works, and essentially what they can expect. I'd like to thank you very much for your time, and I wish you very well in your journey in the field of cochlear implants. Thank you.